Thank you, Dr. Ahmed. Thank you for the committee for inviting me to this absolutely fantastic, meeting. So the question is, how far should we go? I'm going to start with a case that is 1 week old. I was called, I had a call last week for an immediate cath for a 50-year-old man who suddenly had a sudden cardiac arrest in the supermarket. He was very lucky because right behind him there was a nurse that started immediate bystander life support, and the emergency medical system came about 10 minutes after, and unfortunately they had a refractory cardiac arrest. In other words, they were doing multiple cardioversions and the patient was still in recurrent VF. So basically it's a problem, refractory cardiac arrest. What should we do? How far should we go? This is the answer we have in the Paris area. For the several years, we have an extra an Ecmo system that is done out of the hospital. In other words, there's a team that goes out on the scene of the refractory cardiac arrest and implants an Ecmo. As I can see, it's been done in several parts of Paris, in the Louvre, supermarkets, in the streets, and in the subway. And therefore, this was the answer to this patient. He had the team that went out, implanted an Ecmo, and then after he came to the cath lab, where we found an occluded arterial LAD, implanted a stent. And I got some news from him yesterday. They just weaned him from the Ecmo. He's still in the intensive care unit probably for several weeks, but he is alive, and he has the ejection fraction has gone from 20% to 50%. So we're going to come back on refractory cardiac arrest after, but I'm going to focus my talk very similar to what was presented before on the cardiac assist devices and see what is the evidence in cardiogenic shock and acute myocardial infarction. And so therefore we have several mechanical circulatory supports, intra-aortic balloon pump, Impella. I won't talk about the tandem heart and the Ecmo. The IBP, well, I think the story is well said now, is that basically there's a study that has been published from out in several years with a 1-year follow-up, the IB shock trial, which demonstrated that there was no difference between, in a patient that has an acute MI and cardiogenic shock, between medical therapy and the use of IABP. So basically there is theoretically a limited role for balloon pump. What about the Impella? The Impella, as was shown previously, I think the advantage in the emergency setting is that it's a very easy device to use. It's relatively rapid. You get it running in approximately 5 to 10 minutes. Percutaneous, you get up to 3.5 or 4 liters, just like starting in a Ferrari on an autoroute, on a highway. It really works beautifully. What is the evidence behind it? There are some registry data that are in favor of the use of the Impella. This is a registry that we published when we were having the 2.5 in France. But when you look at more evidence, the evidence is not in favor of the Impella support in acute myocardial infarction. This is a matched pair IB shock 2 trial, a study where they took patients that had either a balloon pump in the IBP study, and after they matched it to patients who in Germany had received the Impella, and actually there is an increase of local vascular complications and in fact an increase in mortality in this study. And another study that was done in the US showing that when you use the Impella, and in this case there was approximately 50% of patients who were done in acute cases, when you use the Impella, you actually increase your local complications and you increase your mortality compared to the area when you were not using the Impella. There is one randomized trial that was performed in Amsterdam, randomizing patients between the Impella CP and the aortic balloon pump, stopped early with only approximately 50 patients in each group, no difference between Impella and the intra-aortic balloon pump. So basically, I'd say that there's not very much evidence for the moment. There is a randomized trial that is ongoing, the Dan shock trial, that is having very, very difficult time including patients, and that will give maybe a more definite answer on the use of the Impella for cardiogenic shock. One thing that was said before in the discussion, don't forget, with all devices, there is complications with a 7 to 10% local complication rate with the Impella, and compared to the previous indication where the Impella is pulled out immediately or a few hours after the procedure. In this case, hemolysis usually appears after about 24 or 40 hours and can be a real complication. Third, mechanical circulatory support, VA Ecmo. VA Ecmo is more difficult to use in the acute setting. It's going to take you more time to set it up. You need a team to go and work with you to be able to use the Ecmo. So it's less user-friendly than the Impella. And once again, we have many registries that have shown that if you use Ecmo in cardiogenic shock complicating acute myocardial infarction, you will probably get a more favorable outcome than without Ecmo support, but there is no randomized data. We have just started in July in France a randomized study on patients that have cardiogenic shock due to STEMI, where we're going to control no Ecmo versus Ecmo. This is called Anchor trial, and we hope that in 2 years we're going to be able to randomize enough patients to be able to answer to that question. Once again, with Ecmo, with Impella, there are local complications, limb ischemia, as you can see here, that are between 7 and almost 30% in some of the studies. So there's no randomized data on cardiac assist, so what should we do? What should the interventional cardiologist do when he's got a cardiogenic shock? I think if you got one slide to remember in my presentation, that's it. And that's a conversation I was having with one of the panelists before. Don't forget that the only randomized study that has demonstrated an efficacy in cardiogenic shock due to an acute myocardial infarction was the shock trial that showed that PCI improves survival. So basically the message today is, okay, we've got all these fancy devices, but basically if you open up the artery and you've got an open artery, you've done the job and you've helped your patients. And that is maybe the most important message to remember. If you have devices, cardiac assist devices, and I believe that this should be done in selected patients in tertiary centers that have experience and that can randomize patient or follow these patients in registries. The Impella is easy and fast. It's only a 14 French catheter. It's going to produce unloading. I agree with what was said previously. It should be inserted before and at the beginning at the procedure and not after when things get difficult. It's going to provide rapidly up to 3.5 liters per minute. However, it does no right ventricle support. The Ecmo provides oxygenation, left and right ventricle support, up to 7 liters per minute. It's got more local complications, it's more complicated to do, and it gives no LV unloading, which can give some difficult follow-ups after. So basically, the Impella is a device to use when you go no right ventricle dysfunction at the echo, and the Ecmo is probably to use when you got LV and RV dysfunction and you need oxygenation. What about refractory cardiac arrest? What should we do for refractory cardiac arrest? Well, I gave you the solution that is proposed in-hospital cardiac arrest for refractory cardiac arrest. We have done this, used this system for proxy since 2010. We published our first result in 2013, where we didn't have a very good result, 7 patients, 1 survivor with CPC1. And then after we selected our patients, including only patients who are less than 65 years old, who have no low flow, which means they have immediate basic life support, and in cases where we can have the Ecmo running in less than an hour. And as you can see, we currently have a 38% survival risk. There are also series and studies that have been performed by teams that use the Ecmo in the cath lab. In other words, the patient comes in and they implant the Ecmo and they do a coronary angiogram in very selected patients, and they also have a high survival rate around 38%. This is the study that comes from Minneapolis, showing a survival rate of 42%. So how far should we go? In conclusion, the data on cardiac assist and the cardiogenic shock is limited. The most important message is open the artery. Cardiac assist should be used in selected patients in dedicated centers with predefined protocol, inclusion trials and registries, according to the protocol I've given to you. And refractory cardiac arrest can maybe Ecmo and coronary angiogram can be performed in selected patients by dedicated teams. Thank you for your attention.